Imagine taking your fifth round of antibiotics for a urinary tract infection this year, but the burning just won't stop.
Ugh. Yeah, that is a miserable cycle to be stuck in.
Right. Your doctor tells you it's just a stubborn bacteria. You're drinking cranberry juice, you're altering your diet, doing everything right.
It doesn't help.
Exactly. The pain and that constant need to run to the bathroom, it only seems to be getting worse. What if the problem isn't bacteria at all?
Right.
What if your body is like actively remodeling its own architecture, slowly sealing over the urinary opening with scar tissue?
I mean, that is the harrowing reality for a massive, often completely silent demographic of patients.
Yeah.
They're trapped in this medical blind spot, basically fighting a structural breakdown with chemical Band-Aids.
Which brings us to the mission for today's deep dive. We are investigating a very specific, highly impactful question regarding a chronic skin condition called lichen sclerosus, or LS.
And we've got a really solid stack of sources to go through today.
We do. We're pulling from the 2021 European Guideline for the Management of Vulval Conditions, the British Association of Dermatologists guidelines.
Some great clinical patient leaflets too, right?
Yes, from the Royal Berkshire Hospital. And crucially, the European Association of Urology guidelines on urethral strictures.
That last one is huge.
It really is. So our core question for you, the listener, is this. Can lichen sclerosus affect the external urethral meatus, which is the medical term for the urinary opening in women?
Right.
And if so, what are the exact symptoms you need to be looking out for?
This is such a critical investigation. I mean, this condition operates in the shadows. It's frequently misdiagnosed for years. Yeah, and the impact it has on a person's daily quality of life is just staggering.
Okay, let's unpack this. Before we even get to the urethra, we need to establish a baseline. What exactly are we dealing with? What is lichen sclerosus?
Well, at its core, lichen sclerosus is a chronic inflammatory skin disease. The guidelines specifically define it as being lymphocyte-mediated.
Let's break the mechanics of that down for the listener. So, lymphocytes, those are white blood cells, right? Like the specialized soldiers of the immune system.
Exactly. They're designed to hunt down foreign invaders. Viruses, dangerous bacteria.
But in a lymphocyte-mediated autoimmune condition like LS, the targeting system of those soldiers just gets completely scrambled.
It does. They turn their weapons on the body's own healthy tissue.
Wow.
It's basically a relentless case of immunological friendly fire. And in women, this battle primarily takes place in the anogenital region, so the vulva and the area surrounding the anus.
And when this friendly fire happens, the skin obviously reacts.
Very intensely, yeah.
The sources mentioned the most frequently reported symptom is an intense, sometimes agonizing itch, particularly at night.
Right, the night itching is a hallmark.
And visually, doctors are trained to look for what the European guidelines describe as porcelain white papules or plaques.
That visual description is very intentional. I mean, the skin literally loses its normal pigment.
It turns white.
Yeah, it takes on a white, shiny, almost crinkled appearance. It looks shockingly like fragile tissue paper.
Wow.
And it frequently forms a really classic figure-of-8 pattern circling the vulvar and anal areas.
Okay, so we have this intense, localized inflammation and these fragile white patches. But to understand how the urethra gets involved in all this, we have to look at what LS actually does to the skin's structure over the long term.
Because it doesn't just stay a surface-level rash.
Right. It's not just a rash.
Far from it. Lichen sclerosus is categorized as a scarring dermatosis.
Meaning it causes physical scars.
Exactly. The continuous, unchecked inflammation leads to profound physical changes in the tissue. The medical literature describes two simultaneous, almost contradictory processes happening at the cellular level.
Okay, what are they?
Atrophy and hyperkeratosis.
Let's start with atrophy. That means the skin is thinning out, right? Like the structural integrity is failing.
Precisely. The immune system is essentially dissolving the scaffolding underneath the skin, the collagen, the elastic fiber.
The support system.
Yeah. And because that support structure is gone, the skin becomes dangerously fragile. Patients experience fissuring, where the skin literally splits open from the slightest movement.
Oh, wow.
Or they develop tiny blood blisters because the capillaries underneath are completely unprotected. They're easily damaged by just basic daily friction.
But then you mentioned hyperkeratosis, which sounds like the skin is building up, not breaking down.
I know, it sounds counterintuitive. This is where the body's response becomes chaotic. Hyperkeratosis is the skin thickening.
Okay.
While the deeper layers are being destroyed, the very top layer of the skin basically panics.
Just tries to defend itself.
Right. It tries to defend against this constant inflammatory attack by rapidly overproducing keratin. and that creates stiff, leathery, thickened plaques.
So it's like a chaotic construction site. You have one biological crew tearing down the foundational scaffolding, making the skin tissue paper thin, while
Yes.
another crew is frantically pouring concrete on the roof, making it stiff and leathery.
That is a perfect analogy. And as these dual scarring processes progress, the body starts to heal itself incorrectly. Scar tissue begins to bridge across gaps that are supposed to remain open.
Causing things to fuse together.
Exactly. We see what the guidelines call a massive architectural change. The labia minora, the inner lips, can literally resorb. They shrink and flatten out completely until they essentially disappear.
That's terrifying.
And the clitoris can become entirely buried under a thick hood of fused, scarred tissue.
Wait, I have to challenge this premise for a second.
Sure.
I'm looking at the European guidelines here, and they clearly state that lichen sclerosus spares the inside of the vagina. Like, it respects that internal border.
It does, yes.
So why on earth would it aggressively attack the urethra? I mean, the urinary opening is literally millimeters away. Why does the immune system respect one boundary but completely ignore the other?
What's fascinating here is the microscopic anatomy. The immune system is actually being very specific about the type of tissue it attacks.
Okay, how so?
Well, the inside of the vagina is lined with mucosal tissue. It's non-keratinized, meaning it doesn't have that hard, protective outer protein layer. LS generally does not attack non-keratinized mucosa.
So the inside of the vagina is safe because it's built differently at a cellular level.
Exactly the point.
Mhm.
But the external structures, the labia, the clitoral hood, and crucially, the outer edges of the external urethral meatus, they are covered in keratinized epithelium.
Ah, so it has that protein layer.
Right. The urinary opening sits right on the transitional border between the inside and the outside world. Because the meatus is surrounded by the very skin that is vulnerable to this intense scarring, it gets caught directly in the line of fire.
Wow. So that answers our core question with a definitive yes. The urethra is absolutely impacted by the scarring process. It's surrounded by tissue that is simultaneously dissolving and fusing together.
Which leaves the urinary opening entirely vulnerable to being narrowed or even partially sealed over by the advancing disease.
Now that we've established the mechanical reality that the urethra is physically in the path of this architectural breakdown, we need to translate that into the everyday experience.
The human element.
Exactly. If you're listening to this, what are the specific sensations? What are the physical red flags that this is happening to your body?
Well, the clinical sources outline a very distinct symptom breakdown when LS encroaches on the urinary opening. The first, and honestly most direct, is dysuria.
Which is pain or severe burning when passing urine.
Yes, intense burning.
I want to visualize the mechanism there. We're talking about skin that is severely atrophic, missing its protective layers, and covered in microfissures.
Right, all those tiny splits in the skin.
And urine is naturally acidic, right? It carries waste products. This isn't just a mild sting. It sounds like pouring battery acid on unprotected nerve endings on a daily basis.
That is a highly accurate way to describe the pain level for these patients. The normally harmless acidity of urine is hitting raw, inflamed, structurally compromised tissue directly.
That's excruciating.
It really is. And the next symptom, which is heavily emphasized in the patient leaflet from the Royal Berkshire Hospital, involves changes to the flow of the urine itself.
Okay, how does the flow change?
They explained that the skin edges around the urethra can become fused together, creating what we call adhesions.
So the actual opening, the exit route, is literally getting smaller.
Yes, which forces the urine to find whatever exit it can. The Berkshire Hospital leaflet notes that this partial blockage causes a symptom they refer to as spraying.
Oh, spraying. It's the classic thumb over a garden hose scenario.
Exactly.
Like if you have a full bladder pushing the same volume of water out, but you restrict the opening with scar tissue, the water doesn't flow in a smooth, predictable stream.
No, it scatters.
It sprays everywhere.
The adhesions completely disrupt the straight stream. And, hand in hand with that spraying, women experience a noticeably poor or weak urinary stream.
Because the opening is narrowed.
Right. The opening is physically narrowed, which means the bladder muscle has to work significantly harder to push the fluid through that tiny aperture. That results in a restricted, prolonged flow.
So you have severe burning, unpredictable spraying, and a weak stream. I mean, that's an exhausting ordeal every single time you need to use the restroom.
The physical toll is massive. And it cascades further up the urinary system, too.
Really? How far up?
Well, the sources note that this narrowing and localized irritation lead to increased frequency. The patient feels a constant nagging need to pass urine. They can even develop a condition known as abacterial cystitis.
Let's define a bacterial cystitis for a second. That means they're presenting with all the hallmark symptoms of a bladder infection, right?
Yeah, exactly.
The deep pelvic pain, the pressure, that frantic urgency. But when you test the urine, there is zero bacteria causing it.
Right. The intense inflammation happening at the external opening is essentially echoing all the way up the urinary tract.
It's an echo of pain.
Yes. The nervous system is registering the trauma at the meatus and triggering bladder pain, even though the bladder itself is completely sterile.
Here's where it gets really interesting, though. When you dig into the British Association of Dermatologists guidelines, they highlight a physiological phenomenon called the Koebner response.
Oh, yes. The Koebner response is arguably the most critical piece of this entire puzzle. It explains the rapid acceleration of the disease in this specific area.
Let's explain the mechanism of this because it creates a brutal, self-perpetuating cycle. So the Koebner response dictates that physical trauma or friction to the skin acts as a trigger.
Right. It actively summons those confused lymphocytes to the site of the injury.
And that causes new lichen sclerosus plaques to form. The guidelines mention mechanical triggers, like tight clothing or horseback riding, but they explicitly list exposure to urine as a trigger.
And that's the kicker. When acidic urine hits those microfissures we talked about, the damaged skin cells release chemical distress signals called cytokines.
Okay, cytokines.
To a normal immune system, those signals just mean, hey, send repair cells to fix this cut.
Yeah.
But to a body with lichen sclerosus,
It misinterprets it.
completely.
Ugh.
Those cytokines act like a flare gun saying, concentrate the autoimmune attack right here.
That is an absolute nightmare scenario. I mean, the disease narrows the opening. That narrowing causes the urine to spray unpredictably across a wider area of fragile skin.
Right.
The acidic urine damages that skin, which triggers the Koebner response. The immune system rushes in, creating more plaques, which causes more scarring, which further narrows the opening.
It's a vicious cycle. The very biological act of emptying the bladder becomes the primary trigger for the disease to progress and seal the meatus further.
It's a fire that uses water as its fuel.
Wow, yeah, that's a powerful way to put it.
Which leads us to a massive systemic problem in how we treat patients. I mean, think about it. If a woman is experiencing a weak stream, spraying, constant bathroom trips, and a burning sensation, any doctor listening to this is immediately thinking one thing: a urinary tract infection.
Oh, 100%.
Tell me that isn't exactly what these patients are being treated for.
If we connect this to the bigger picture, that misdiagnosis is the exact trap millions of women fall into. The symptoms of urethral lichen sclerosus perfectly mimic a textbook UTI.
So they go to the doctor.
The patient goes to the clinic, the doctor hears burning and frequency, and their training immediately jumps to a bacterial culprit.
So they ask the patient to pee in a cup, they test the fluid. Even if the culture comes back completely clear of bacteria or maybe, just shows a tiny trace of generalized inflammation, the doctor hands them a prescription for antibiotics just to be safe.
It happens all the time. The patient takes the full course of antibiotics. But because you're throwing a bacterial solution at a structural autoimmune skin disease, it's like trying to put out an electrical fire with a bucket of water.
It doesn't work.
Not only does it fail to fix the problem, you're wasting precious time while the tissue continues to scar. The symptoms persist, or maybe they vanish for a day and then just come roaring back.
And the patient goes back to the clinic exhausted and still in pain.
And what happens? The doctor prescribes a stronger antibiotic.
Unbelievable.
Or they refer the patient out, diagnosing them with generalized pelvic floor dysfunction or an overactive bladder or interstitial cystitis. The patient enters this cycle of medical gaslighting. Unintentional, perhaps, but still devastating.
Right. They're told it's a stubborn bacteria, or perhaps it's just stress.
Meanwhile, the actual underlying condition, the lichen sclerosus, is ravaging the local anatomy completely unchecked.
Because the medical professionals are staring at the plumbing, they're testing the fluid in the pipes, while completely ignoring the structural integrity of the house itself. Nobody's looking at the skin.
Exactly. And leaving this architectural remodel unchecked leads to the severe, potentially irreversible complications that are outlined in the EAU guidelines on urethral strictures.
Let's focus on those EAU guidelines because this is where the long-term danger becomes undeniable. For the listener, EAU is the European Association of Urology.
Right, and their clinical data on this demographic is striking.
What does it show?
If the scarring from lichen sclerosus is allowed to progress around the urethra without intervention, well, it can form a true stricture.
Which is a huge deal.
Very much so. The medical term is female urethral stricture, or FUS.
To be clear, a stricture isn't just like inflammation. It's a rigid, permanent narrowing of the tube, right? The scar tissue has hardened and calcified to the point where the hose is permanently squeezed shut.
That's right. And historically, urology has viewed urethral strictures almost exclusively as a male problem.
Really?
Yeah, often associated with the male equivalent of LS, which used to be called balanitis garotica obliterans. The medical establishment simply didn't look for strictures in women, but the EAU guidelines actively challenged that blind spot.
They highlight how significant this pathology is in the female population. So what do their numbers actually say?
The data reveals that between 2 to 29% of women presenting with refractory lower urinary tract symptoms have a physical obstruction.
Okay, let's translate refractory lower urinary tract symptoms for the listener. That refers to women whose urinary problems flat out refuse to get better with standard treatments.
The women stuck on their 5th, 6th, or 7th round of useless antibiotics.
Precisely those patients. So up to 29% of them aren't failing treatment because of stubborn bacteria. They're failing because they have bladder outflow obstruction. Something is physically blocking the exit route.
Yes, and of that obstructed group, between 4 to 20% will be diagnosed with a true fibrotic urethral stricture.
Those are staggering numbers. I mean, if you take a waiting room full of women who are at their wits' end, crying out for relief from chronic UTIs that won't go away, a massive chunk of them are actually dealing with a physical roadblock made of scar tissue.
Exactly. Furthermore, the guidelines note there is a markedly increased incidence of this in women over the age of 64.
Which links perfectly back to the pathophysiology of lichen sclerosus, because LS sees a major secondary peak in postmenopausal women.
Yes, the biological timing creates a perfect storm. After menopause, the profound drop in estrogen fundamentally alters the urogenital tissue.
The skin gets thinner.
Right. It naturally loses elasticity, moisture, and resilience. It becomes inherently more vulnerable. So when you take tissue that is already compromised by estrogen deprivation and you introduce an aggressive autoimmune scarring condition like LS,
It's a recipe for disaster.
the risk of the meatus fusing into a severe stricture skyrockets.
And fixing a calcified true stricture isn't something you can just do with a pill.
No, definitely not.
Well,
Once a dense fibrotic stricture has fully formed, it often requires invasive surgical intervention to physically cut open the waterway and restore function. The tissue has been fundamentally altered at a structural level.
so what does this all mean? Let's bring all these threads together for you listening. Our mission today was to uncover if lichen sclerosus can affect the urinary opening in women and what the daily reality of that looks like.
And we found our answer.
We did. The answer is a resounding, medically verified yes. The immune system's confused friendly fire doesn't just cause itching, it drives an active, aggressive architectural shift that can actually seal the urethral meatus.
Right.
The symptoms you need to watch for are direct physical manifestations of the skin fusing and scarring over that opening. Urine that sprays wildly, a noticeably weaker stream, intense burning when acidic urine hits those microfissures, and a constant, urgent need to pee triggered by localized trauma.
And the reason we dive this deep into the mechanics is because knowledge truly is power.
Absolutely.
In this specific scenario, knowledge can prevent irreversible surgical complications. If you, or a partner, a mother, or a friend are caught in an endless loop of chronic, unexplained urinary issues, if you're taking antibiotic after antibiotic for UTIs that never seem to cure the underlying agony, it is time to advocate for a fundamentally different diagnostic approach.
It is time to demand that the doctor look at the structure, not just the plumbing, to thoroughly examine the skin of the vulva and the meatus, rather than just endlessly testing the urine in a plastic cup.
Because if lichen sclerosus is identified early in the process, it's actually highly manageable.
That's the good news.
It is. The dermatological and urological guidelines are unanimous that the application of ultrapotent topical steroids, specifically ointments like clobetasol propionate, are incredibly effective.
The steroid steps in and basically shuts down the friendly fire.
Yes, it suppresses those confused lymphocytes at the local level. And if you halt the inflammatory attack early enough, you stop the atrophy and hyperkeratosis before it permanently alters the anatomy.
You save the blueprints before the house remodels itself into a trap.
Exactly.
That is a profoundly hopeful takeaway. Early intervention completely changes the trajectory of a patient's life, but it requires the medical provider to look in the right place.
Which raises an important question, and it's a paradigm-shifting thought I really want to leave you with today.
Let's hear it.
In modern medicine, we've developed this rigid tendency to separate our bodily systems into highly isolated silos.
Oh, for sure. It's the way the entire healthcare system is built. If you have a skin problem, you're sent to a dermatologist. If you have a urinary flow problem, you're sent to a urologist.
And if you have a vulvar concern, you wait months to see a gynecologist. We divide the human body into strictly guarded territories.
Right.
But autoimmune diseases like lichen sclerosus do not respect those artificial borders. Here we have a primary skin condition that aggressively causes profound urological and gynecological failures.
Wow.
So what if the key to solving a massive portion of chronic postmenopausal urinary suffering is hidden right there, languishing in the blind spot between these specialized medical fields?
That reframes everything.
If a localized skin condition can perfectly masquerade as a complex, intractable urological failure for a decade, it forces us to wonder—
But what else are we missing?
Exactly. How many other incurable daily discomforts that people are just suffering through are simply waiting to be viewed through a different medical lens?
How many other locked doors are just waiting for someone to recognize that the keyhole has been covered up? We started this deep dive talking about the terror of a body remodeling itself without permission. It is a frightening biological reality, but it doesn't have to be the end of the narrative.
Not at all.
Because once you understand the mechanics, once you recognize that the blueprint is changing, you can intervene. You can stop the remodel. You don't have to just accept that the doors are closing. Keep asking questions, demand that your providers look beyond the obvious silos, and never let anyone convince you that living with chronic, unexplained pain is just a normal part of getting older.